Hello and welcome. Today, we're diving into the world of congenital heart defects, focusing on a condition called coarctation of the aorta, or COA. We'll explore what it is, why it happens, how it affects the body, and what can be done about it. Whether you're a medical professional, a student, or simply curious, this video will provide a comprehensive overview of COA. The exact cause of coarctation of the aorta isn't fully understood. It's considered a congenital defect, meaning it's present at birth. In most cases, it's believed to arise from errors during the development of the aorta in the womb. Genetic factors may play a role, and it can sometimes occur alongside other heart defects, such as a bicuspid aortic valve or ventricular septal defect. It's important to note that there is usually nothing the parents did or didn't do that caused the coarctation. Coarctation of the aorta essentially creates a narrowing or constriction in the aorta, the body's largest artery responsible for carrying oxygen, rich blood from the heart to the rest of the body. This narrowing forces the heart to work harder to pump blood past the obstruction. Blood pressure increases before the coarctation, leading to higher blood pressure in the upper body and arms. Conversely, blood flow and pressure are reduced beyond the narrowing, resulting in lower blood pressure in the legs and feet. This discrepancy in blood pressure has significant consequences for organ function and overall health. Coarctation of the aorta affects approximately 1 in every 500 to 4,000 live births, making it a relatively common congenital heart defect. It affects males slightly more often than females. While it can occur as an isolated defect, it's frequently associated with other heart abnormalities. Early diagnosis and intervention are crucial to prevent long-term complications. The signs and symptoms of coarctation of the aorta can vary depending on the severity of the narrowing. In severe cases, newborns may exhibit symptoms like difficulty breathing, poor feeding, and cold or clammy skin. Infants may develop congestive heart failure. In milder cases, the condition might not be diagnosed until later in childhood or even adulthood. These individuals may experience high blood pressure in the arms but low blood pressure in the legs, frequent nosebleeds, headaches, leg cramps during exercise, and cold feet. Diagnosing coarctation of the aorta typically involves a thorough physical examination, listening for heart murmurs, and checking blood pressure in both arms and legs. An echocardiogram, using sound waves to create an image of the heart, is often the first-line diagnostic test. This can visualize the aorta and assess the severity of the narrowing. Other diagnostic tools include a chest X-ray, which can reveal an enlarged heart or rib notching, due to increased blood flow through collateral vessels, an electrocardiogram, ECG, to assess the heart's electrical activity, an MRI or CT scans for detailed images of the aorta. Coarctation of the aorta can be classified based on the location and severity of the narrowing. It can be preductal, juxtaductal, or postductal. Preductal means that the coarctation is before the ductus arteriosus, which is a temporary blood vessel connecting the aorta and pulmonary artery, which closes shortly after birth. Juxtaductal is near the ductus arteriosus, and postal is after the ductus arteriosus. Also, we can classify it depending if there are other heart defects involved. A coarctation can also be discrete, a localized and short narrowing, or long segment, which indicates the narrowing happens in a longer region of the aorta. Treatment for coarctation of the aorta depends on the age of the patient and the severity of the condition. In infants with severe coarctation, prostaglandin E1 may be administered to keep the ductus arteriosus open, which can improve blood flow to the lower body until surgery can be performed. Surgical repair involves either removing the narrowed section of the aorta and reconnecting the healthy ends, resection and anastomosis, or widening the narrowed area using a patch of tissue, a patch artroplasty. Another option, especially for older children and adults, is balloon angioplasty with stent placement, where a balloon catheter is used to widen the narrowed area, and a stent is placed to keep it open. Long-term management includes regular monitoring of blood pressure and cardiac function to detect and manage potential complications like recoarctation or hypertension. Unfortunately, there's no known way to completely prevent coarctation of the aorta since it's a congenital condition. However, ensuring optimal prenatal care, including adequate folic acid intake, may reduce the risk of congenital heart defects in general. Genetic counseling may be beneficial for families with a history of congenital heart disease. The prognosis for individuals with coarctation of the aorta is generally good, especially with early diagnosis and treatment. However, even after successful repair, long-term follow-up is essential to monitor for potential complications like coarctation, hycoarctation, aortic aneurysm, or premature coronary artery disease. Recent research focuses on improving surgical and interventional techniques to minimize complications and optimize long-term outcomes. Studies are also investigating the genetic basis of CoA to better understand its causes and potentially develop preventative strategies in the future.